Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
My guests today are Dr. Sonny Yamasaki and Dr. Scott Nickerson. I consider both of them very good friends, but more importantly, they are a couple of the smartest people I know, and I've been so fortunate to get them together for this episode, as they are dedicated in getting the message out about reversing the symptoms of diabetic peripheral neuropathy, and perhaps even more important is the fact that this type of surgery can reduce the annual recurrence rate of diabetic foot ulceration from 30 to 40% per year to less than 5%, much lower in fact. Dr. Yamasaki is the president and co-founder of Enso Medical Technologies Incorporated. He's a graduate of the Rutgers Medical School, now the Robert Wood Johnson Medical School, and the University of Medicine and Dentistry in New Jersey Graduate School of Biomedical Sciences. He is a neurophysiologist who studied recovery mechanisms of injured cerebral cortex in the visual and oculomotor systems of awake, behaving, non-human primates. Maybe that's why he gets along with me so well. He conducted his research as a postdoctorate fellow and later a scientific staff fellow at the National Eye Institute, which is part of the NIH. He also acted as an assistant professor at the University of Wisconsin Medical School in Madison, Wisconsin. In his corporate career, he was a technical fellow and lead stroke expert for Medtronic PLC for 17 years. Dr. Scott Nickerson is a retired orthopedic surgeon who practiced in rural Wyoming for 20 years until he was forced from practice into early retirement because of symptoms from diabetic peripheral neuropathy. Soon after his retirement, he crossed paths with Dr. Lee Dellon, who is a retired professor of plastic and neurosurgery at Johns Hopkins, who was also my mentor in nerve surgery. And after having very successful nerve decompression surgery, his symptoms greatly improved, and he then focused on getting this message out that symptoms of diabetic peripheral neuropathy could be reversed in properly selected patients with nerve decompression surgery. After he became interested in this, he jumped in with both feet, has written many articles, has designed research protocols, and has been really dedicated in all things diabetic peripheral neuropathy for the last 2 decades. His situation of being a careful and competent clinician and an attentive observer of the progression of his own neuropathy gives him a special perspective. Explaining this revolutionary surgical approach for neuropathy to patients, practitioners, surgeons, and academics is his continuing commitment. Dr. Nickerson plans, promotes, and participates in many academic conferences, patient care, and research projects to define the place of nerve decompression surgery in preventing and treating neuropathic complications. In this episode, we discuss some incredible and very important physiology that is known as pressure-induced vasodilation. Please enjoy this fascinating conversation I have with these two full-fledged brainiacs, where we talk about nerve decompression surgery and how well it works in preventing recurrence of diabetic foot ulceration.
All right, everyone. Welcome to the Pod of Inquiry. I'm here with two of my favorite colleagues because I have to really listen to all that they have to say because they have too much to say, and it just is like asking for a drink of water and getting the fire hoses turned on. So without any further ado, Dr. Sonny Yamasaki, can you tell the folks kind of your background, how you got into what you're doing today with Dr. Nickerson? And Dr. Nickerson's been on the show already way back in the first season, but and then after Sonny gets done maybe give a little snippet of how you got to where you were here today, Scott.
After you, Sonny.
Okay. So I'm a neurophysiologist by training. Did my postdoctoral training at the NIH, National Eye Institute, and then was a research professor at the University of Wisconsin Medical School. I had to step down from that because my fiance was diagnosed with ALS, and I couldn't continue putting 70 and 80 hours a weekend. So I went into semi-retirement, moved to California, took care of her. And in the process, I did a seminar. I was teaching gross anatomy at Sonoma State University part-time. And I got a call from Medtronic asking if I can give a seminar on blood flow and the blood vessels. So we brought a bunch of prosected cadaver parts into Medtronic. One thing led to another. I saw what a great company that was and started working for Medtronic. And that was the vascular division where they make the stents, catheters, and balloons. So I worked there for, 7 or 8 years and became, with my brain research background, the lead stroke expert for Medtronic, and continued to be that for the next, for 15 years in total. I was transferred to the Jacksonville, Florida facility, which was the ear, nose, and throat and neurosurgery division, to help them acquire a stroke company. Let's see. And it was there, they are the company that makes the intraoperative nerve monitor, the NIM, nerve integrity monitor. And I got a call from the senior director of marketing and said, "Hey, Sonny, I want you to go out to California and look at this case. They're claiming that they can do a nerve decompression and see improvement literally within seconds." And I said, "Tino, that's impossible." And he said, "Well, go and look because they're using the NIM intraoperatively and they can show an improvement." So I went out and my jaw dropped. The case went from about 125 microvolt EMG signal. He decompressed the nerve and then stimulated the nerve again, and it went from 125 to about 1500 microvolts. And I thought, well, what's going on here? I thought I understood the nervous system, but this shouldn't happen. So I spent the next, close to 20 years working with AENS to try to understand why this can happen and how it's happening, what the mechanism of action is, et cetera. So that's how I was introduced to AENS.
Right. And Scott, why don't you just give a little quick background, because your story is really compelling as well.
Okay. I'm trained as an orthopedic surgeon, and in my training at the University of Cincinnati, I had a lot of exposure to foot problems. And so I was interested in feet difficulties when I went to small town America, and I practiced orthopedic surgery for 20 years in Sheridan, Wyoming, which is a big town of about 18 or 20,000. Along with the practice there, I was particularly interested in foot problems. And then along the line, I developed diabetes, and then it got uncomfortable enough that I wanted to retire after about 20 years. So I have not worked professionally as an orthopedist since 1997. But some years later, 5 or 7 years later, I came across the information that Dr. Lee Dellon, plastic surgeon at Johns Hopkins University, who was a contemporary of mine, although we didn't know each other, he was operating on diabetics for their diabetic foot pain. And I thought, well, that's the craziest thing I've ever heard of. The diabetic neuropathy is known to be progressive and irreversible. And then I thought, well, maybe you better find out something about this, because this is why you aren't doing orthopedic surgery anymore. Well, one thing led to another. Dr. Dellon did operate on my feet, which had numbness, but not too much pain. And then I got involved with you, Steve, and the Association for Extremity Nerve Surgeons, and eventually with Dr. Yamasaki, who was interested in trying to figure out why this stuff work? Why did nerve decompression work? Why should a scalpel be effective in reversing diabetic neuropathy and its complications? So that's how I got into this. Dellen challenged me to start writing about my thoughts and what we were seeing. And so that's kind of what I've been doing nearly full time most of the last 20 years, is trying to understand this. And we think we finally got a handle on why nerve decompression is effective in diabetic neuropathy and its complications.
That's really interesting, because when I first started crossing paths with Dr. Dellen, I was so skeptical as well, because it was beaten into us for decades that there's nothing you can do for this except tell them to live with it and maybe take some gabapentin. And so when I started seeing the results of Dr. Dellen's patients, when I spent time with him up in Baltimore, it caused a lot of sleepless nights. And this was a whole paradigm change. And I think for me, it was, all right, you've been under this belief that there's nothing that can be done for a long, long period of time. But now you've actually seen it with your own eyes. These patients were coming back wanting their other leg done. They had reestablishment of their sensation, reduction or elimination of their pain. And so it didn't take me very long to realize, after several patients that I saw in this clinic the very first day, that there is a lot of merit to this. And when I started doing it, the first thing that patients would often say is, when can I have the other leg done? And that really wasn't common in a lot of the things that we do. And so just looking at the numbers of the people that came back for their other side, it's like the ultimate study, because people are not going to come back for something if they don't get a good result, or at least a satisfactory result. So it was very interesting to see that. And then actually now we're here 20 plus years later, and you guys are doing great work that we want to talk about the actual neurophysiology of what's going on after nerve decompression. So with that, why don't you guys talk about the paper that you have just submitted, I believe, and we can go from there to some of the other topics.
Scott, why don't you give sort of an intro on what the paper is, and the fact that it's a critical review, et cetera.
Very good. What we began to understand after some more work that Dellen did along with one of his postgraduate fellows, who is Oscar Asman and now a professor in Germany, they found that in people who didn't come back for that surgery, that second surgery to relieve pain in their legs, those people, if they had only unilateral decompression, later on over the next 5 years, often went on to have either toe amputations or develop a diabetic foot ulcer. And interestingly, none of those complications occurred in the operated leg. 100% of them occurred in the opposite leg. And if I remember right, it was something like 15 amputations or ulcers over the next 4.5 years in 50 patients. So it's a 30% incidence of complications, and it never happened in the leg that had had nerve decompression. So that's, Dellen threw that at me and said, why don't you start thinking about this and read the literature and all of that? So that's what started me on writing about things. And we ended up having a number of papers that were observational papers. They were not prospective. They were not randomized controlled trials, but they all showed that you hardly ever had an ulcer recur after you've had nerve decompression. It neither occurred nor recurred if you had a prior ulcer. So that's all interesting, and we published it. It didn't seem to gain much traction. And finally, in about, I think it was 2019, the people who were skeptical of this surgery, which included almost all neurologists and most wound care professionals in academia, they were saying, you should never do this surgery, just do standard of care. And I got kind of angry about that. I said, here's all this good observational information, and nobody seems to be paying any attention. So I said, Sonny, please join me. Let's talk about this. Maybe we can do an analysis and come up with good information that will make people think twice about their rejection of surgery as a way to deal with diabetic foot problems and diabetic peripheral neuropathy, or DPN. So we then started reading. I think we probably went through 500 papers. And in that process, we came up with a couple of good information, good articles that seemed to indicate to us that it was autonomic nerve damage that could be relieved by nerve decompression that was at fault for the problems with diabetic foot ulcer and its complications. So what do I want to do to get to the...
Let me add one thing to that. And the last sentence that you stated about the autonomics and its mechanism really refers to diabetic foot ulcers, not to all the other symptoms that we've also looked at.
Right. I think, Scott, before you try to get to the PowerPoint, there's so much that you just said right there that I want to unpack it a little bit for the audience, because first of all, we look at different things from this perspective. We look at the pain of the individual that is suffering with the entrapments and the diabetic peripheral neuropathy. We look at restoration of sensation. We look at maybe improvements in balance. These are all very, very important aspects. And I think that the point that you made, where you get the contralateral benefit from an ipsilateral surgery, I'm sure we're going to get into that a little bit later, but pain is usually something that really puts people in the doctor's office versus a potential for a recurrence of an ulceration. It's something that is just higher up on the order of perception of these individual patients. So that kind of took people down a wrong path, because one of the great things about this is the reduction of the recurrence rate of ulceration. That, to me, yes, pain, I want pain gone for my patients, of course. But if I can keep that patient from having a reulceration or a recurrent reulceration, that's a big deal, not only for them, but for their family members, as well as the global healthcare system as well. So I think you said a lot there. I just wanted to make sure that the audience picked up that there's more components than just than pain.
I'll just add that what we know about diabetic foot ulcers is the ulcer count, the incidence from, I think this was 7 or 8 years ago, and it was 300,000 people a year in the U.S. of A. that have a diabetic foot ulcer. It's supposed to be 3 to 5% per year risk for a diabetic with neuropathy. So about half of those are recurrences, and about half of them are new ulcers. So if you can deal with people that have pain and are at risk of getting this ulcer, and we ought to be able to pick those people out with some of our technology scanning for blood flow, and we can avoid the recurrences that are half of the ulcers, we're going to cut down a whole lot of problems, pains, expenses, life-changing events, and those often move on to amputations and early demise. So that's why being able to understand why nerve decompression works and why we ought to be considering using it much more frequently in people with diabetic neuropathy and especially the diabetic foot ulcers, that we can do a whole lot for people's lives and the expenses of medical care for diabetes.
Absolutely. Sonny, you have anything to add to that?
Nope.
Okay, very good. All right, can you share your screen with us now, Scott?
Scott, before you get started, I want to let everyone know that that's not how my name is spelled.
It's D-W-A-Y-N.
There we go. Yeah, N-E. Yeah.
God. Sonny, how many times do I have to do that wrong?
Oh, man.
Okay. So I'm just going to start with the next screen, I guess.
Okay.
what we're doing here is we're talking about diabetic sensorimotor peripheral neuropathy. Most of the time I call this DPN in this presentation. But what we need to think about is just what is it that we call DPN? What is the etiology? And in academia, the etiology is uncertain, complex, and generally lumped together as a symmetric dying back of axon, which they call LDA, or length-dependent axonopathy. And this is kind of how they look at it. I don't want to go through this bit by bit, but the academics understand that hyperglycemia is at fault, and it goes through a number of changes in the metabolism, which ends up in microvascular insufficiency. It is recognized that microvascular insufficiency is a big part of the diabetic foot problem, and it's caused by diabetic peripheral neuropathy. And this has been recognized since at least the 1980s. And these hyperglycemia independent pathways are other things that they throw in to understand in academia what is diabetic peripheral neuropathy. Another way that they look at it, I'm going to show in this is a current paper from Frontiers in Endocrinology, and they show that the hyperglycemia, the vascular disease, and the neuropathy are all involved in, along with trauma, in developing what they call the diabetic foot, and in this country we call that diabetic foot ulcer. If you look at the blue area that I have up there on the neuropathy group, you'll see that they do recognize autonomic problems. But the way it's recognized in terms of the diabetic foot is that you have dry skin with fissures, and that's as far as they go with it. Mm-hmm. What Sonny and I believe at this point is that it is the entrapment neuropathy that is a big part of the autonomic changes, and that this happens through another metabolic process called the polyol pathway. Most of our learning about glucose metabolism and energy generation recognizes the hexokinase pathway, which generates glucose 6-phosphate. And that's the way we all learned it in medical school or physiology. But this second pathway, the entrapment neuropathy disrupting the polyol pathway, is what Sonny and I think we have contributed that has not been understood, and that gives us an explanation for why nerve decompression can work. Here's Dr. Dellon, who was a contemporary of mine at the Johns Hopkins Medical School, and then went on to become a professor of plastic surgery and now retired. But his ideas were what led people to start operating on painful diabetic neuropathy. And the neurologists and endocrinologists never bought into this approach. They said, what in the world can a scalpel have to do with a metabolic problem? That can't be an effective. We are very skeptical. However, there are some neurologists, including these two fellows, Rhoda and Morelli, who are Italians. They, in looking at diabetes mellitus, said that entrapment neuropathies are so frequent at any stage of diabetes that they can be considered the neurophysiological hallmark of peripheral nerve involvement in diabetes. Well, how does that happen? How do we connect diabetic neuropathy, nerve decompression, and the impaired skin microcirculation that we feel is so important in the occurrence and recurrence of diabetic foot ulcers? So this is the paper that lays out the ideas that Dr. Yamasaki and I have encountered as we went into great depth in reading about the processes that are involved. Here's a way to think at it. In red here, we have indicated that hyperglycemia can saturate that normal hexokinase pathway, which leads to glucose energy production. But there is an alternate pathway that is a minor pathway to begin with, but becomes more and more important as you get into hyperglycemia. And this alternate polyol aldose reductase pathway functions and accumulates sorbitol and fructose within the neuron and axon, and that leads to an intra-axonal hyperosmolarity such that fluid migrates into the axon, enlarging its size, and a big fat nerve is what results. Well, there's a few places along the pathway of the nerve, and they're usually at fiber osseous tunnels that are near joints where there isn't room for a fat nerve. So the enlarged nerve in its anchoring fiber osseous tunnel gets into a situation of compression. And over on the right side, we show these steps with aldose reductase leading to increased sorbitol, with sorbitol dehydrogenase then increasing fructose, and those staying within the membrane of the axon and causing the hypoosmolarity. That swollen nerve trunk then gets compressed at the ostia of the tunnel, and you get an entrapment neuropathy. So,
Scott, can I interject?
Please.
Can you back up one slide? Previous slide. So one thing to note the figure that you had there. There we go. So one thing to understand is that there are, as everyone knows, there are glucose transporters in the membrane of the axons, but there are no transporters for sorbitol or fructose. So the sorbitol and fructose that get manufactured within the axon are trapped, and they'll continue to accumulate, as Scott said, over time, and create an ever-increasing hyperosmolarity, hyperosmolar situation. So more and more fluid gets transported into the axon, and the nerve continues to swell really for the lifetime of the patient.
Before we continue with this great discussion, I just want to take a quick break to acknowledge this week's sponsor. This episode is sponsored by Savant Cellars, providers of boutique Tier 1 Reds at a Tier 2 price point. Let's imagine you are spelunking in a cave out in Napa Valley, and you come across some of the juice from Savant Cellars. You may just never want to come out until it's gone. Savant Cellars sources all of their fruit from the really big-name boutique vineyards. That's right, where the elites get their fruit. If we put a vineyard designation on our bottles, we would be contractually forced to sell our wines at 3 to 4 times our current pricing. Yes, full disclosure, I am one of the 3 principals, and I'm very proud of our wines. Savant Cellars is the genius of wine. Simply great wines, vintage after vintage, crafted in a Bordeaux style so you can lay them down for years or drink them now. They simply just get better. Use the code SPELUNK15 to get a 15% discount at savantcellars.com. That is CEVANT sellers.com. Spelunk15.
I explain this to the general public as nerves passing through the tunnel, which are of a certain size, and it fits in the tunnel, which is represented by the white band. As you get diabetic, the nerve swells. You get a pinch there in the fiber osseous tunnel. Nerve decompression releases that compressed spot, and the nerve functions better. With nerve decompression, the high pressures in the axon, which are 60 to 100 millimeters of mercury, are reduced then to less than 10 millimeters. And you, Steve Barrett, were involved in the MACE study that demonstrated that. Here's what Sonny was just describing in terms of what goes on in the nerve. On the upper left there in the healthy nerve, we see a fiber osseous tunnel represented as that blue wall and the nerve. and axons represented in yellow. The membrane of the nerve is represented at the right, and we can see that there are a few sorbitol and fructose molecules, which are red and yellow, inside the intracellular space, but they're a small amount. And the blue-green square and the blue water molecules are in equal numbers inside and outside the membrane. In the diabetic nerve, you can see accumulation of the red and the gold sorbitol and fructose molecules on the intracellular side of the membrane. They can't be transported or diffused across the membrane because there are no transporters. But the water and the glucose can be transported by aquaporin transporters and GLUT transporters so that they're equal on both sides of the membrane. What ends up happening then is in part C, that's the summary of the polyol pathway, which leads to a fat nerve being trapped inside fibroosseous tunnels.
So let me interrupt 1 second here because what you guys just said, I always wondered why if you look at the molecular weight of sorbitol and glucose, they're actually pretty similar in Daltons. I can't remember the exact numbers, but I was always trying to figure out why was it that sorbitol is so much more hydrophilic than glucose. But what you're saying is it may not be a molecular weight situation at all, which I didn't think it was because of the similar Dalton weight. But it's because there's no transporter for sorbitol or fructose in the cell membrane.
The sorbitol and fructose are isolated to the intramembranal space, and they can't be the osmolarity cannot therefore be ameliorated by transporters or diffusion. So that is why it gets fatter and fatter, as Sonny was explaining.
Well, that's very, very interesting because I always like to know what is really the physiology going on here. That makes so much sense.
One thing that we should mention for the experts out there, cell membrane experts, there are sorbitol and fructose transporters in other cell types, but just not in the axon. So, for instance, in the small intestine, you will see those transporters.
So that's a very special situation that applies especially to nerve, and it is responsible for this necessity of changing the nerve compression situation. So let's see. Then knowing what's going on in diabetes, what are the situations in which you might be using nerve decompression? Diabetes is the primary situation where you will see that nerve decompression might be appropriate to treat pain in diabetes or to deal with the preventing the initial diabetic foot ulcer or its subsequent recurrences, which lead to the complications of amputation and early mortality. There are other nerve decompression advanced topics where people are very happy to have nerve decompression to deal with these other situations, which we have listed here. But the main thing and the most common is in diabetes. So in terms of diabetic foot ulcers, here's the list of awful complications that we see with diabetes and the diabetic foot ulcer. I'll just mention the ones in red. It's amputations, recurrences, and mortality. And this is what we have been emphasizing in our current publication and in another paper that we'll shortly be submitting, which deals with more of the other physiology involved in the diabetic foot ulcer problem. But the summary is that if you can avoid the diabetic foot ulcer and its recurrences, this is very likely to improve your survival and maintenance of an intact limb and life itself. So what's going on in this? Go ahead, Sonny.
Can I interject? So two slides back, you had in the other scenarios where ND may be appropriate is chemotherapy induced neuropathy. And Steve, I called you a few years ago about a friend of mine who had what I thought was a chemotherapy induced neuropathy, and she had tremendous heel pain. And the nerve going to the heel goes through a tiny window, right?
Yep.
And I asked you, hey, in these patients, do you see a swelling of the nerve from the chemotherapy-induced neuropathy? You said yes, right?
Right.
So are they as swollen as the diabetic neuropathy nerves?
Sonny, I don't know that I could really opine because we've seen so many more cases of diabetic peripheral neuropathy than chemo. I've never really, made that observation, but I can tell you that I think there's two types of chemotherapeutic induced neuropathy, and one is the edematous and the other is the non-edematous. And if we can address the edematous, we have a pretty good chance at relieving their pain, improving their function. The non-edematous would be more, I guess we're kind of drawing the analogy here because I think it's very important. The semantics of what we're really doing is we're not operating on diabetic peripheral neuropathy. We're operating on multiple superimposed nerve compressions that are caused by this edematous phenomenon that occurs. I think the same goes for the chemotherapy as well. If it's a swollen nerve, we can do something for it. If it's not, then that means that it's just too intraneural and it's beyond anything that we could hope to benefit from decompression.
I think this is interesting because this person, her uncle was there, who was the chief endocrinologist at University of Virginia. And I asked him, I said, I talked to your niece about her heel pain, and I think it could be this chemotherapy-induced neuropathy. And he said, yeah, we're aware of that. And I said, did you realize that this may cause a swelling of the nerve? And he said, absolutely not. I had never heard of that before. So even experts, which goes along with what Scott has been lecturing on for 20 years, these people, the neurologists and the endocrinologists, never see the nerve like you guys do, the surgeons.
Right.
So they have no idea, well, unless they've read the few papers that have been out there, they're not aware of how much swelling is going on in these cases. So,
So, Sonny, and I think you were there too, Scott. Remember when we had Todd Levine come in, who's a great neurologist out in Phoenix, and you had the NIM, and intraoperatively, we were doing exactly what was the impetus for you to kind of become more involved with the Association of Australian Neurosurgeons. That was this almost instantaneous improvement in EMG function intraoperatively. And I recall Dr. Levine saying to me, I've never seen this nerve. I've studied it, but neurology by training just doesn't really, they just don't, they're not in the cadaver. Let's put it that way.
Yeah.
One other thing about the heel pain is that not only can you have an edematous nerve, but you can have multiple branches. And I can remember Lee Dellen cussing me out for having 7 different branches of the calcaneal nerve that he had to locate and decompress. So it can be more complex.
So I bring it up because I think the chemotherapy-induced neuropathy is worthy of further study.
I agree. And those people are so desperate. It's pretty amazing. But the interesting thing that I've seen, and I don't want to say the majority of cases, but just at the top of my mind, just looking at my clinical experience, it seems like there's this predilection for common fibular nerve involvement. And it seems to spare some of the other nerves distally, which is surprising. You would think it would be just the other way around. But that's just an observation. I don't have anything to really substantiate that other than just the observation.
Interesting.
So
I can go ahead.
Yeah, go ahead. Go ahead, Scott. I mean, there's so much here.
Okay, well, let's think a bit about the circulation to the skin in terms of diabetic foot ulcers, because everybody believes that it's skin hypoxia that is, the final, pathway for development of an ulcer. And circulation is an important part of keeping that epidermis alive. And once you've lost your epidermis, then usually the wound continues into the dermis, and until you start doing the proper standard of care treatment, which is unweighting of the ulcer area, most people cannot reverse that situation. So here's the anatomy to refresh us. The epidermis is the very top layer. It's generated by the papillary layer of the epidermis. Circulation to this area comes from little arteries and veins in the subcutaneous tissue, and then they begin to divide in the reticular dermis layer. And in that reticular dermis layer, there are arteriovenous anastomoses. We're going to, here in this next slide, it shows these as occurring kind of in the deep dermis, but I think I want people to have a few moments to think about arteriovenous anastomoses. These are low resistance connections between small arteries and small veins, and normally the sympathetic nervous system shuts those anastomoses down. That's the situation in the normal skin. But when you have diabetic neuropathy and you damaged your sympathetic functioning, those anastomoses can open up and you get a wide open flow through those anastomoses. So you have fast flow in the deeper layers of the dermis, but you are stealing that from the subpapillary capillary beds. So the capillaries that feed the epidermis of the skin, they're being robbed by this shunting. And this is what, in our mind, generates the hypoxic effect that make the skin so much less resilient and resistant to compression and normal walking and standing. So it's a vascular steal from the capillaries that feed the epidermis. I think go ahead, Sonny.
Can I interject that? This figure shows the anatomy nicely, but it doesn't show the AV shunt really at all. Here we go. This is a much better figure for explaining the shunt itself. Okay, Scott, sorry.
So in the left image, there's a red arrow with a blue bar in it, and it's labeled AV shunt with a black arrow pointing to it. Over on the left, underneath the label epidermis, there's another black arrow that shows the subpapillary capillary plexus. This is the epidermal nourishment and oxygenation there. If we look over to the right side here, we can compare normal skin microcirculation on the left to diabetic skin microcirculation on the right. And so on the left, we'll this vascular loop going from arteriole at the bottom to venous exit on the left, there are two pathways of flow. One is through the AV shunting, and in the normal situation, your sympathetic nerve has that shut down to minimal flow. It's normally contracted, and most of the blood flow goes right up into the skin capillaries, which are nourishing the papillary epidermis. However, on the right, with the yellow coloring, you have skin microcirculation change. So with loss of sympathetic control, the AV shunt opens up wide open. You got heavy flow right on into the venules, which will exit to the left. And associated with that, you have a little vasoconstriction, which shuts down the arterial supply into that capillary loop. So you have a a less oxygenated supply up to the papillary cells which generate the epidermis. So that's why in diabetes you've got good blood flow, but it's not going where you need it in the epidermis. It's going right through and on into the venous system. And people have known for 40 years that you can have increased measured blood flow in the diabetic foot, but not in the epidermis. So that's the thing that has been in other publications, but not appreciated by the people dealing with wound care, diabetic foot ulcers, and nerve entrapments. So here we are. I guess I should have shown this more directly, but we've just explained it, and I think I'll go on to the next slide.
Scott, before you let me interrupt just a second, because I know you're going to want to talk about pressure-induced vasodilation. Do you want to maybe hit that now with this diagram, or this doesn't have any relationship to that?
This will come up with the next 3 and 4 slides.
Okay.
Okay, so we have in this situation called chronic capillary ischemia. So what? Well, we think that understanding that blood flow is damaged means that this chronic capillary ischemia shown in the previous slides may be a critical factor in the development of the diabetic foot, its hypoxic damage, and the complications follow it. The thing is that there has been no effective treatment known, but PIV, pressure-induced vasodilatation, is an expression, a second expression of this loss of blood flow to the skin because of loss of sympathetic control. This graph is showing in the y-axis the laser Doppler flow, and it measures from 100% in the normal situation and follows with a blue graph what happens in the normal foot when you stand on with application of increasing pressure fairly gently and over time. You get an increase in the blood flow that averages up to 45% when you're standing on the foot. But if you have diabetes, you get the red graph of what happens to your blood flow as you're standing on your feet. You have no increase in pressure, increase in flow with pressure application. You just have continued loss of flow as pressure increases over time. So this is your pressure-induced vasodilatation, which is lost in diabetes.
And now, a message from our sponsor. Well, folks, if you're over 40 and you're not using a supplement to augment nitric oxide production, you should really rethink that. This molecule is absolutely imperative to health, not to mention the cardioprotection. Nitric oxide is a physiological molecule that does so many things for your health. I never miss a day of nitric oxide supplementation. That's how important it is. Long overdue, there is now a nitric oxide replenishment formula without the fear of oxalates. Approved Medical Solutions does not use beets, spinach, or arginine. Approved Medical Solutions is proud to offer our audience their oxalate-free nitric oxide formula. If you are not a healthcare provider, you can still get started by going to approvedmedicalsolutions.com and use the code SBarrett at checkout, and you will receive a 10% medical discount savings. For licensed practitioners, just go to approvedmedicalsolutions.com and register. They have unique bundles for all of the full-fledged spelunkers of the Pod of Inquiry. Use Pod of Inquiry at checkout after registration, and I am certain you will be pleased not only for yourself, but for all of your patients. Here's a little secret. If you order their testing strips and test every patient for a few clinic days, you will see that nearly every one of them will be deficient. When they see this result, they will want you to start them on it immediately. Now, thanks to Approved Medical Solutions, you can give them the best care without the worry of oxalates. Thanks for watching. You can start today.
We hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes, found at our website, podofinquiry.com. If this incredible and educational conversation has tickled just a little bit of your cortex, please leave us a review and spread the message to your friends and colleagues. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show, if used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.